So now we're going to move on to talk about bone health and treating metastatic castration-resistant prostate cancer. So Noel, I'm going to turn to you first. I know you have a strong research interest in bone metastases in prostate cancer, and can you tell me a little bit about the symptoms of bone metastases for patients with prostate cancer?
Well, it's not that well understood actually, and given the scale of the problem, not that well researched. So we have patients who develop bone metastases, and we know that the majority of men who die from prostate cancer have some bone metastases, at least 90%. And I think if you looked hard, you'd find it in most patients. And some of those are asymptomatic. Some of those are highly symptomatic, and some of those are associated with pathological fracture cord compression. Now, what we know is that the process of bone formation and bone destruction is very rapid in prostate cancer, and people have looked over years at the radiological appearances and said, well, these are osteoblastic metastases, aren't they? And of course, when you look at the bone breakdown markers and look at how the skeleton is being broken up by prostate cancer, you see, rather surprisingly, that prostate cancer is a more lytic disease than, for example, breast cancer, than lung cancer, and for some of the grossly lytic disease. So I think it's important to understand that what you're seeing is that the whole metabolism is booted up. And one of the things that is important to try to recognize is that there are certain patients who've got high risk of developing skeletal-related events. Now, in the older classification of SREs, for example, in the old bisphosphonate studies, the SREs were radiological, and people were looking at little bits of radiological fractures and so on. In the later studies, the Alsimca study is a very good example of this, they were clinical events. So SREs were either a pathological fracture, cord compression, radiotherapy to bone, or treatment of bone pain. And that's the group to focus on. And what we're really interested in doing in treating prostate cancer is trying to avoid an SRE, which is in some cases a catastrophic event, and in many cases is predictable. There are certain markers that you can look at, really where the Mets are, how heavy the skeletal load is, and two key markers which are underutilized in my view, alkaline phosphatase, lactate dehydrogenase. Two critical things. If the alkaline phosphatase is above 150 and the LDH is up, you've got a heavy skeletal load, that's a patient who's going to run into trouble.
Yeah. And Nick, in your practice, you see a lot of patients with bone metastases, obviously. Sure. Is there any characteristic that you warn patients to watch out for with regards when they have bone metastases? So again, one of the things we have charted out on our electronic systems at the QE is ALK-Phos. So I'll sit and look at two graphs in these patients. I'll look at what the PSA is doing, but I'm looking very closely at the ALK-Phos. If the ALK-Phos is climbing, and if it's above the normal range, that sets alarm bells ringing, particularly in patients with a large metastatic burden. I mean, one of the things we will do with these patients proactively is we have, and I'm sure a lot of other centres have this, we have spinal cord compression cards. So if you get these symptoms, phone this number, don't wait till your next appointment, because obviously it's much easier to prevent these things or manage them early than, you know, when somebody's paraplegic, mostly it's too late, as you know. So I think that there's that, and I'm very keen on being very proactive about, for example, irradiating these patients. I'm also very, I mean, we're having a lot of debates with our purchasers at the moment about how much we have to give, because a lot of the data around palliative radiotherapy is around 8 Gray as a single fraction in an era where patients were living a few months with multi-metastatic disease. And it's not the same treating 1 or 2 Mets in patients who are going to live for years. You know, I think durability of control is much more of an issue, and I think that the stereotactic literature is very much trending in favour of dose escalation if you're treating relatively small numbers of Mets. So I think where we're going to be in a few years' time is that if for patients with low metastatic burden, we're going to try and irradiate them before they ever get a problem. So that's not really, that's palliative in a sense, but it's a very different sort of palliation. Yeah, it's a longer term strategy.
You're old style.
You're trying to give the patient a longer period of time without symptoms of the bone metastases.
And I think the second thing is that, and we see this very clearly from the abiraterone trials, the enzalutamide trials, from the docetaxel part of Stampede, the abiraterone Latitude and Stampede, is that if you give an effective anti-cancer therapy, your rate of symptomatic skeletal events drops. So like in Stampede docetaxel, upfront dosi reduced by 40% your risk of SREs 8 years later. So it was a profound and long-term effect. So I think, in general, the best way to palliate cancer is to treat the cancer, not to do something else. But I think the thing that's been debated over the last few years is if you're giving an anti-cancer agent, do you need to give bone protection as well? And I think back in the era that the SARD, zoledronic acid trials were done where people were living a couple of years, the answer was probably no. People simply weren't living long enough. And whereas now, as survival times go up, bone health, I think, is going to become increasingly important in metastatic disease. And I think the ERA 223 trial, which I know we're going to discuss in a minute, shows very clearly that the Abbey patients in that trial had substantial rates of fractures, non-cancer fractures as well. So I think we need to think both about the cancer-related fractures, but also the bone damage of all these other drugs we're giving to treat the cancer.
So, Noel, yeah?
Well, I was just going to add, it's been a constant source of frustration, really. There's a lot of level 1 evidence about how to use these drugs. Yeah. And there's the issue of bone protection in relation to androgen deprivation, which we're going to come on to.
Yes.
And there's the issue of preventing the pathological fractional cord compression associated with metastatic sites. Yeah. And what's clear is that, and the level 1 evidence in relation to denosumab, very well done trials, is that you really have to target these therapies. And the zoledronic acid, or any bisphosphonate, is very different to denosumab. So if you give a bisphosphonate, the dose is cumulative. It gets into the bones, you don't get it out of the bones, it's very tightly bound in. And if you're treating anybody who's likely to survive longer than 2 years, you should give very careful thought to whether you should be giving the drug early or whether you should delay it. And the same is true of denosumab. So we come back to what Nick was saying a few minutes ago, which I was saying earlier, which is the rate of change of the alkaline phosphatase is critical, because that group of patients in the LDH level, that group of patients will not survive a long period of time. They're likely to die within 12, 18, 24 months. And that's the group of men who will potentially benefit from a drug like a bisphosphonate or denosumab. Don't give it to somebody who's got a single 2 or 3 mets and have them on this drug for 4 years, because your rate of osteonecrosis of the jaw will go up.
But I think there's 2 considerations here, isn't there? So, I mean, what you're talking about is reducing the rate of SSEs due to bone cancer. And so Stampede did test that to the ultimate limit. We put the zoledronic acid in at the beginning, and we saw no benefit on cancer-related SSEs, and saw indeed ONJ. And all of that's, so the ONJ and so on is predictable. But there's the second set of effects, which I think we need to be worried about as well, is the osteoporotic effects. Now, you don't need to give, you only need to zoledronate once a year to stop osteoporosis, not once a month. Yeah. And it's twice a year, whatever is the dose for denosumab. So I think there are 2 separate indications for these. So I think the osteoporotic indication, and that comes out from the ERA 223, is something we actually increasingly need to think about, which we never needed to think about in an era when patients weren't living very long.
So long, yeah.